All right, let's jump right into this. Welcome to today's Explainer, where we're breaking down an absolutely critical, high-stakes topic you're guaranteed to see on the NCLEX and out there on the med-surg floor: meningitis. We're going to make the pathophysiology, the priority interventions, and those tricky NCLEX traps crystal clear so you can recognize them instantly. Let's get started.
Picture this. Your patient rolls in complaining of a stiff neck, a pounding headache, and a fever. Sounds like a nasty flu, right? Well, maybe not. Because it's the way their knees suddenly betray their neck that reveals the real killer hiding inside. We are talking about a rapidly escalating neurological emergency where literally every single minute counts. So what are we dealing with? Meningitis is inflammation of the meninges. Think of the meninges as these tight, protective membranes hugging the brain and the spinal cord. Now, we've got to draw a hard line here between viral and bacterial. Viral or aseptic meningitis is usually much milder, but bacterial meningitis, that is a rapid, downright deadly threat. It skyrockets intracranial pressure and can throw your patient right into herniation or shock. It's a true medical emergency.
Section 1. Pathophysiology, the ticking clock.
Let's walk through exactly how this killer operates. First, the pathogen invades. A bacteria or virus sneaks into the meninges, maybe through the bloodstream, a sinus infection, or severe head trauma. Second, inflammation hits hard. The immune system freaks out, mounting this massive response that inflames the meninges and the cerebral spinal fluid. Third, and this is where it gets deadly, edema and increased ICP. All that swelling and trapped fluid ramps up the pressure inside a totally closed skull. And finally, step 4, neuronal injury. The brain literally gets squeezed, causing altered levels of consciousness, deficits, and eventually seizures.
Section 2. Signs and symptoms. Spotting the threat.
You absolutely have to memorize the classic triad here. We're talking fever, nuchal rigidity, which is just a fancy term for a super stiff neck, and altered mental status. Toss in a severe headache and photophobia, which is an intense, painful sensitivity to light. If you catch this combo on a test question or at the bedside, your alarm bells need to be ringing loud and clear.
Now, let's talk about those classic meningeal signs. First up is Kernig sign. This is when there's severe pain on knee extension while the hip is flexed. Then we have Brudzinski sign. That's when you flex the patient's neck and their hips and knees involuntarily flex to take the stretch off that inflamed spinal cord. To lock this down for test day, just remember this hook. K is for knee, which goes with Kernig's, and B is for brain and neck for Brudzinski's. Do not forget that one.
All right, major red flag warning here. If your patient has the stiff neck and the fever, but then suddenly breaks out in a spreading petechial or purpuric rash, you know, those little purple pinpoint blood spots, that is a full-blown meningococcal emergency. It means the infection has hit the bloodstream, your patient is actively tipping into fulminant septic shock and DIC, meaning they're basically bleeding out and clotting at the exact same time. It truly does not get more critical than this.
Section 3. Diagnostics, confirming the culprit.
Before we even think about treating, we need to dodge a massive NCLEX trap. To actually diagnose meningitis, we need a sample of cerebral spinal fluid from a lumbar puncture. But, and this is a huge but, if your patient is showing any signs of increased intracranial pressure, like a shifting level of consciousness or pupil changes, you must get a CT scan of the head before doing the LP. Why? Because if the pressure in the brain is critically high, draining fluid from the spine can literally cause the brain to herniate right down through the base of the skull. CT first if ICP is high. No exceptions.
Okay, so once we safely snag that CSF, what are we looking for? Well, bacterial meningitis is incredibly ugly. The fluid looks cloudy or turbid. The protein levels will be sky high thanks to that massive inflammatory response, and the glucose, critically low. Why low? Because those hungry bacteria are literally eating the glucose for energy. Viruses, on the other hand, don't eat glucose, so viral meningitis fluid is clear with totally normal glucose. Cloudy fluid, high protein, low glucose, that absolutely screams bacterial.
Section 4. Priority interventions, saving the patient.
Priority number 1, droplet precautions immediately. Get them in a private room, throw on a surgical mask. Meningococcal meningitis spreads like wildfire through respiratory droplets. Priority number 2, antibiotics stat. Do not wait for those lumbar puncture results to come back. You draw blood cultures if you can do it without delaying, and then you blast those bacteria with empiric IV antibiotics instantly. Literally every single hour you delay drives up the mortality rate.
Moving on to step 3. We need to manage that increased ICP and immediately initiate seizure precautions. Elevate the head of the bed to help with venous drainage and do your neurochecks frequently. Step 4.
Keep the room quiet and dark. Remember that photophobia we mentioned? Bright lights and loud noises can trigger agonizing pain and even seizures when the brain is that inflamed and irritable. Keep all stimulation to an absolute bare minimum. And finally, don't forget about the people outside the room. For bacterial, specifically meningococcal meningitis, we have to provide prophylaxis for close contacts. That means family members, roommates, and yes, healthcare workers who were exposed to respiratory secretions before isolation was set up need prophylactic antibiotics, like Rifampin, to make sure this deadly bug stops spreading right then and there.
Section 5. Test yourself. NCLEX active recall.
All right, let's put this into practice. Question 1. A client is admitted with suspected bacterial meningitis. Which precautions should the nurse implement immediately? Is it A, airborne precautions, B, contact precautions only, C, droplet precautions, or D, standard precautions only? Think about it and drop your answer in the comments right now. 3, 2, 1.
And the correct answer is C, droplet precautions. Bacterial meningitis, especially the highly contagious meningococcal type, spreads via respiratory droplets. You have got to isolate this patient immediately in a private room with a surgical mask and keep them on droplet precautions until they've had a full 24 hours of effective antibiotic therapy.
Awesome. Let's hit question 2. Let's look at those labs. Which cerebrospinal fluid result is consistent with bacterial meningitis? A, cloudy fluid, low glucose, high protein, elevated WBC. B, clear fluid, normal glucose, low protein. C, clear fluid, high glucose, no cells. Or D, bloody fluid with normal chemistry. Lock in your choice. 3, 2, 1.
You guessed it, the answer is A. Bacterial meningitis produces cloudy, turbid CSF. The glucose is super low because those bacteria are feasting on it for energy, and both the protein and white blood cells are going to be off the charts because of that massive inflammatory immune response.
So here's the bottom line to master meningitis. Droplet precautions plus antibiotics, stat. Keep that memory hook front and center. If a patient walked into your ER right now with a stiff neck and a fever, would you be ready to beat the ticking clock? I bet you would. If this explainer made things click for you, make sure to subscribe. We're breaking down one killer med-surg topic every single day until you confidently pass the NCLEX. Keep studying smart, and I'll see you in the next one.